Good evening, everybody. So we are moving on to an important part of our global fellowship program, and today we are going to talk about the two important topics. So the first topic is on current status of palliative care globally, which will be dealt by Dr. Stephen Corner. And the second topic is challenges to palliative care development in a low middle income country by Dr. Tara Devi. So I don't know how to introduce Stephen because he has been working in palliative care for a long time and a lot of achievements. And if I am going to read the bio, I think it will take about half an hour. So I am not attempting to do that, but I should say that I first met him in 2008, where we conducted the International Association of International Indian Association of Palliative Care International Conference in 2008 at Cochin, and we actually made a standard tool to create minimum palliative care standards in India, and he was one of the main force behind that. But over years, he has been working in various countries, or he has been working to develop palliative care in various countries, including Asia and many other countries. And he has been working in National Hospice and Palliative Care Organization as the leadership for 11 years. But presently, he is the chief executive director of World Hospice and Palliative Care Alliance, WHPCA, which is a which is an alliance of national and regional hospice and palliative care organization worldwide. And he has a lot of publication, and he is also a researcher. I think he has more than 125 articles which was published in peer-reviewed journals, reviews, book chapters, etc. So let me stop there, and let me introduce Dr. Tara Devi. So I think Dr. Tara, when she came to us from Bhutan for doing palliative care course at Trivandrum Institute of Palliative Sciences. I don't remember which year, but after that, she has been doing various activities on palliative care. She has done her diploma in general nursing and midwifery from Royal Institute of Health Science, and then she did her MPH from Chulalongkorn University, and he's a Susha Global Fellow. And recently, she finished her PhD in palliative care from University of Western Australia, and she is working as a senior lecturer, Faculty of Nursing and Public Health in Thimphu, Bhutan. And I welcome both Dr. Stephen Horner and Dr. Tara Devi to this session. And first of all, I invite Dr. Stephen to talk about the current global status of palliative care. Welcome, and it's over to you, Dr. Stephen Corner.
Thank you, Dr. Sunil Kumar, and great to be with all of you. You're the future leadership of palliative care, and we're most happy to support your growth and development. I'm sharing my screen now. Can everyone see it, and can everyone hear me okay?
Yes,
can you hear me?
Yes,
okay.
Yes, you're audible.
Great. All right. Well, so we're going to talk about the current status of palliative care globally, which is something that a number of us researchers have been tracking over the past years, and hopefully share with you some of the challenges as well as the progress that's being made internationally. I have no conflicts of interest, just to note. Okay, so many of you probably have heard of the Global Atlas of Palliative Care, but it's a publication that we do with the World Health Organization that is an advocacy tool for palliative care, and also a sort of benchmarking, to measure progress or lack thereof in palliative care development. I thought I'd talk a little bit about the new public health model for palliative care. Hopefully you've all heard about that, and then some of the barriers and opportunities for palliative care development. I'll try to stick to time here. They're putting on my timer. Good. So now the need for palliative care globally, many of us worked with the Lancet Commission on Pain Relief and Palliative Care to develop a new methodology for determining the need for palliative care globally. And we used that methodology in the second edition of the Global Atlas to measure how many people need palliative care. And we have that data, by the way, for every country. So we couldn't publish it in the Atlas because WHO rules say that if you have to get every country's permission to publish data if you do it at the individual country level. So we did the regions, but we do have data, and we're working with Felicia and the team for Lancet Commission on what we're calling Lancet 3.0, which will be a comparison of the need for palliative care over the past several decades, as well as new data on the need for palliative care. When we did the Global Atlas originally, we estimated about 40 million people needing palliative care, which we knew was an underestimate. But because WHO was somewhat reluctant to overestimate, or they're afraid of overestimating, they really held down the number of people. But we were able, for the first time, really to get WHO to say, officially, that people, not just cancer patients and people with HIV needed palliative care, but lots and lots of other conditions required palliative care. In the original Lancet Commission report, we had 62 million people needing palliative care. And in looking at the numbers, there was a concern that we had overestimated a little bit on terms of the HIV deaths and people needing palliative care while in treatment. And the number was revised down to around 57 million. Bear in mind, we have actually, in the last data published by WHO for 2019, the estimate was about 54 million deaths worldwide. It's now, I think, definitely, probably above 60 million because of COVID-19 and of course the aging of the population globally and increased mortality. We're going to see a significant increase over the next few decades in terms of the need for palliative care because of the aging of the population. But we had about almost 26 million people at the end of life needing palliative care. But we want to make the very strong point that palliative care is not about end of life care. It's about people with serious illness and serious health-related suffering. So a good number of those people, almost half, are needing it at the end of life, but more actually needed prior to the end of life. Most people living in low and middle income countries, and Tara is going to talk a lot more about that in the session after this one. We have mostly older people. We also have children, and we think that the numbers that you're going to see here on need for palliative care for children are definitely underestimates. I did a paper with ICPCN a number of years ago that estimated the total need for palliative care for children at about 21 million people, children, 21 million, 19 and under. And of those, about 8 million of those had specialized needs for palliative care. So making it more like those are the ones who really need to be followed by someone who's trained in palliative care. Lots of people still dying in pain, at least 18 million based on our estimates a year, dying in severe pain. That's probably also an underestimate, given the lack of access to opioids. We'll talk about that. And bear in mind that we have lots and lots of people grieving every year. And we're seeing, particularly with COVID-19, an increase in complicated grief problems, what we now are referring to as prolonged grief disorder, in around 10% at least of the people who experience a death in a given year. And we calculated that actually every year about 1 billion people attend a funeral or memorial service in the world. So a lot of grief. Yes. There. All right, so we said around 57 million people needing palliative care, and that's probably well over 60 million now. And about 7 million receiving palliative care, or only about 12% of the need being met. This is the cover of the Global Atlas, and you'll see that it has two logos, the World Health Organization and WHPCA. And getting that logo took about 3 years of pretty persistent work to try to get WHO to to respond to the need for palliative care. This document and the data in the original version was used as the background information for the publication, or for the World Health Assembly resolution in 2014. So it went a long way to helping WHO, helping us get the resolution passed by having data that we could point to of the need for palliative care. This is, of course, the second edition. Our main purpose was advocacy for the Atlas. We wanted to paint a picture of palliative care worldwide, but also to set a benchmark for palliative care so that we could measure over time changes in the need for and the challenges we're facing in palliative care. We've had a lot of interest in the Atlas, 160,000 copies downloaded of the original, and so far about 87,000 for the second edition. We're trying to answer 10 questions, just making sure people understand what palliative care is, what's the definition, and actually there's more than one definition, but we have to use obviously the WHO definition in this document. How many people need palliative care? What are the main diseases? What are the main barriers? How well is palliative care developed in each country, 198 countries in the world? Where is it available and not available? What are some of the innovative models for palliative care worldwide? What kind of resources are available to support palliative care? Have we seen change over time? And what is our agenda going forward for palliative care? Most people, we've seen this, you've seen this before, I'm sure, but over 73% of all deaths from non-communicable disease. That's the big cause of death globally. Communicable disease still a fairly big cause of death, injuries and poisoning, etc. 8%, that's been pretty stable over time. And maternal, perinatal, and nutritional conditions. The shift has been the increase in non-communicable disease. So this has been a fairly consistent breakdown that about 45% of the need for palliative care is in the last year of life, and 55% prior to the last year of life. And we know people start having palliative care needs, they start experiencing serious health-related suffering very commonly as much as a couple of years or more before actually dying of their condition. The biggest need is for 70 years old or older, particularly the 80 to 85 plus population has grown, though that's primarily in higher income countries. We said 7% for children. It's probably a bit more than that after we get done. We are re-examining all of the conditions that we listed for pediatrics that to try to see if we can get a better estimate, because currently the numbers are underestimates. But also young adults, people of all ages die or need palliative care. We see a little more communicable disease and the need for palliative care because of HIV and TB. HIV mortality has certainly gone down, but it's still 600,000 or 700,000 a year. TB has actually increased during the pandemic as a cause of death to well over 1 million, 1.2 or so million. Yeah, but the need, we do have a need for palliative care for very young children as well, and birth injury and prematurity. Most people live in a lower middle income country that need palliative care, over 3/4. High income countries, 24%. But the biggest need is in upper middle, 38%. You're familiar with all these conditions. Cancer, malignant neoplasm is the largest single category, though. We have, if we add up some of the others in terms of, dementia, cerebrovascular disease, quite a few people with stroke have palliative care needs, and of course HIV, TB, and other organ failure. With children, it's a different picture: congenital malformations, HIV, injury. And injury, in one of the things that we did with Lancet Commission was recognizing the need for palliative care for people with severe injury, which was under estimated in previous estimates. But children have a whole host of different conditions that are, some are similar, but most are different than adults. The need for children is really only about 2 to 3% in high income countries. It's really a problem that is predominantly in low and middle income countries, which is a sad statement about access to medical care globally for children. And children, we know, are less likely than adults to be able to access palliative care. And children are spread out geographically, and they're not concentrated so much in one place. So it's difficult to form these sort of specialized palliative care services for children that are needed. So just taking a look at the need in India as one of the countries that you represent in this group, we have been able to break that down to it's almost 6.5 million people needing palliative care in India. It's a huge number. I don't think we've been talking about trying to break that need down by state so we can see disparities within India in the number of people needing palliative care, but also in the number of people getting palliative care. I mean, palliative care is growing in India in many states, but we haven't done a gap analysis exactly to say, well, here's, is it 5%? Is it 1%? How many people, what percentage of the need in India is being met? But it's a huge need for both adults and children. It's about 8.5% for children in India. So here's the new public health model. Hopefully you've all seen this. It was published in the WHO report on indicators for palliative care that came out of the Atlantis group in Spain, but about 30 of us participated in developing this set of indicators. But we also, you'll recall the old model, the triangle model, the 3 primary components of medicine, training, and policy. But we felt it really needed a refresh. It really needed to be thought out a little more carefully. And so we've seen the addition of community involvement and the importance of community involvement in palliative care development globally. We'll go over each one of these sort of individually, but and also added research to the model. For communities, this year, the theme for World Hospice and Palliative Care Day is going to be compassionate communities together for palliative care. Last year it was healing hearts and communities, and it was around grief and the effects of the pandemic. This year, we see a very strong connection between the development of compassionate communities and the development of palliative care. They kind of can go hand in hand. And the more we see compassionate communities, the more we see palliative care developing. But also, we want to make sure that as we develop palliative care services, that we involve the people with lived experience of palliative care in all aspects of planning and operation of services. I started out in 48 years ago as a volunteer working for palliative care because there were no hospices. I mean, actually, it was before the term palliative care was coined. by Balfour Mount in Canada. And it was the hospice movement, and we were all excited about starting programs in the U.S. But there was no funding, there was no insurance, there was no nothing except the ideas that came from St. Christopher's and some of the earliest programs. But volunteers are still a really important part of it. We did a paper when I was at the National Hospice and Palliative Care Organization on consumer evaluation of services. And we had a thing called the Family Evaluation of Hospice Care, which was a post-death survey. And we kept finding that the one thing that tended to be associated with people giving what we call top box scores, or 5s out of 5s or 10 out of 10s, was how much volunteer involvement there was. And we didn't believe it at first, but we kept studying it. We had over 200,000 surveys coming in a year, and we wrote a paper on this about the importance of volunteerism to how people perceive a service, and whether it's and whether it's at high levels of quality. It was, I think, really more about people perceive paid caregivers differently than they perceive volunteers. When you have the community involved, it feels more like it's bigger than just a service. And communities are still and they still don't know what the public still doesn't know what palliative care and hospice care are. And one of our secrets, of course, in palliative care is the way we lift up family members and involve them in caregiving, and what a positive effect that has on families during care, but also the grief and bereavement afterwards. But families vary in their capacity to provide care, but they involving them is one of our secret weapons, if you will, because there's so much that families can do to care for their loved ones that they just don't know how to do. Okay. Slides advance themselves. So health policy, what do we mean by health policy? I've worked in 26 or so countries, and the first thing that you do if you're working with champions in palliative care in a given country is help them develop an assessment of the need for palliative care in that country. And needs assessment is not just numbers. It's a lot of understanding about culture, about the existing healthcare system, how to integrate into the system, how to understand what level the population is in terms of understanding palliative care. We have data for the need for palliative care, for the numbers for every country, but these sort of formal needs assessment, we have about 35 or so of them on our resources section of our website. But they're useful, and I think in a large country like India, it's good to do it also at the state level, because India is sort of like, in the United States we have 50 states, and every state's got significant differences in terms of how the healthcare is delivered and in effect what the culture is. We also early on need to develop operational standards. Those are not clinical standards. Those are standards for how do you operate a palliative care service in your country. And unless you have those, people are all doing a lot of different things. It's okay in the very beginning for that to happen, but you really need to standardize what you mean by palliative care so that it's delivered consistently in different services around the country. We need, in terms of policy, one of the first things you need is a law that says what palliative care is, that defines palliative care, and then including it in the healthcare system, recognizing it as an area of healthcare specialization. Most countries have palliative care that have specialization, have it as a subspecialty rather than a full-on specialty. There's some reasons for that. And then having actually a national strategy for implementation of palliative care that is funded. If you do I've done a bunch of these national strategies in different countries, and if you don't have actually budget attached to it and some authorization for funding, it's going to sit on a shelf somewhere and probably never be very useful. Right, so research. This was a neglected area in the previous model. We talked about the national palliative care indicators that WHO has that should be used in every country by the government to measure and report on palliative care development. And if you're not familiar with those, it's easily downloaded from the WHO website or from our website. We really need to look at the impact that we're having on healthcare systems from a research perspective. And we think one of the important things to measure is poverty reduction. And actually, there are only a handful of decent studies on poverty reduction, but one of them is from India to measure the impact that we have on the healthcare system and on out-of-pocket expenses for people who are getting healthcare in a given country. Of course, the Donbedian model, structure, process, and outcome measurement. I don't particularly like the term satisfaction, patient satisfaction. It's really leniency biased. And so we talk about experience of care measurement or consumer evaluations of care. We still need qualitative research in palliative care. Of course, measuring the quality is the ultimate goal for us research-wise, because that's our claim, is that we improve the quality of life for people. And then eventually you have a way, then you can, in the United States, we have a thing called Hospice Compare, which is you can go into a website and look up the hospices in your community, and you can compare their quality outcomes. Education and training is really pretty much, I think, probably the biggest part of the house model. I mean, we literally need to be training millions and millions of healthcare professionals. I mean, you shouldn't be able to graduate from medical school, nursing colleges, or mental health training at university without having had some training or exposure, at least into the basics of palliative care. That's our aim, our belief. So it's not just schools, it's also postgraduate, residents, and continuing medical education for those who have been out practicing for a while that that never got any training when they were in professional school, so that we get everyone that is that touches the patient. And training should really be we should incorporate the clinical guidelines in a given country into the training, so that if there are clinical guidelines that are recognized, particularly by Ministry of Health, or whatever body is responsible for teaching and curricula approval, that you build in clinical guidelines into the teaching. We have in many countries a kind of chicken or egg problem. There aren't enough people qualified to teach palliative care in a given country or region, and so you have to build up enough people who have who are qualified to teach palliative care. And not everyone can teach who provides care, so we need people who are qualified teachers who have clinical experience. It's no good if you're teaching from a book. You have to have been at the bedside and spent many hours with patients and families to care. It's interesting. I'm doing a presentation or developing a presentation on this, but actually, when you look at, if you did like a time and motion study and you looked at how much time it takes to manage physical symptoms in palliative care versus how much time we spend with psychological, social, spiritual, and practical matters, at least 3/4 of it is not, strictly speaking, medical symptom management. It's, I'm roughly speaking, around 75-25. And so we neglect training people in mental health skills. I mean, we do our basic stuff of communication skills and breaking bad news, but dealing, understanding family systems theory and helping people with existing, previous mental health issues, well, of course, depression, anxiety, but also a lot of post-traumatic stress gets reactivated when people sometimes are in these caregiving situations. There's a lot that we could be doing, a lot more teaching we could be doing. And we need regional and national training centers to do teaching in palliative care. We're trying to do those at great anchors in different regions of the world, so that and Kerala, of course, in India has really been is really evolved into one of those main hubs for teaching palliative care. So I really applaud Pallium India and the folks in Kerala who are doing teaching. You're really a model for other regions of the world. And of course, we have primary, secondary, tertiary training. So I mean, if your basic palliative care training typically is around a week or two. Someone who's going to work in palliative care at the sort of intermediate level needs at least a couple of months of training. A lot of that is at the bedside, shadowing someone who's experienced in demonstrating competence before being let loose, if you will. And then specialist training is at least a year for subspecialization and 3 years or more for specialization. And as far as education, we shouldn't neglect the community. The community needs to be trained, or needs to be sensitized and understand what palliative care is about. And we have kind of an opportunity to define what we mean by palliative care, because most people don't know what it is. We'll get into some of the data on opioid usage in a moment, but the essential model list of essential medicines that WHO publishes and updates with the help of our friends at the International Association for Hospice and Palliative Care. That model list should be available, not just available, but affordable and accessible in every country. And we know that close to 80% of the world population is not getting adequate access to essential medicines for palliative care. And that's not just opioids. We use a lot of antidepressants, antiemetics, anti-seizure meds, coanalgesics, constipation treatment. And a lot of this is, I think we've analyzed the problems. We've published a lot about it. We have the cooperation of the International Narcotics Control Board and the Commission on Narcotic Drugs, but we just can't seem to get countries to change their behavior. And it does mean it's a complicated thing. Because to me, it's like a water line that's going to your house that has several different valves that turn on or off the water. If one of those valves is closed, you're not going to get water. And it's the same with medicine. If one aspect of the supply chain process, which we don't have time to get into this morning, but this evening, but you have to make sure every issue is addressed in order to succeed in getting, especially controlled medicines. And we deal with, in some countries I've had, the police been very problematic in terms of harassing physicians who prescribe opioids, and we've had to develop special education programs just for drug control authorities, including the police. And get rid of rules that are completely ridiculous or unnecessary in terms of accessing or even dispensing opioids. So when we say we're going to provide integrated palliative care services, we can never meet that tens of millions of people need without integrating palliative care into primary care, into existing healthcare systems, especially primary care. But really, the palliative care, in hospice has this sort of mythology about being a building you go to when you're dying. But we all know that it's predominantly home-based care that we're talking about. And many countries don't actually have systems for delivering home-based care. So they need to be built from the ground up in some cases. We do need some inpatient care. The percentage of days in hospice in the United States that are done in an inpatient facility, hospital or inpatient hospice or palliative care unit is only less than 2% of the days of care. Almost 98% of the days of care are at what we call routine home care level, which is wherever that is, the place a person calls home, whether it's their own house, you know, a homeless situation, or assisted living or nursing facility. We also need, in terms of integrating into healthcare, to be able to effectively provide consultative services in inpatient facilities where people often are identified as needing palliative care. And of course, that's primary, secondary, and tertiary as well. So what are the barriers? I mean, I think we can use that new public health model to really effectively say what the barriers are, which are lack of access to medicines, lack of training, lack of policies that enable the provision of palliative care in countries, lack of programs that deliver integrated services, lack of research and evidence, and lack of community involvement. So it's been pretty consistent since we started measuring this, that the global consumption of morphine is only about 5 milligrams per capita. We see in the darker shaded parts of the world where essential medicines like morphine are available, which is North America, Western Europe, and Australia predominantly. That needle has not moved very much since we started measuring this back in early 2000s, late 90s, early 2000s. And of course, we have, you know, a problem with North America and Australia with opioid use disorder, problems with overdose and opioid use disorder that are not seen in most of the rest of the world. And we don't. There are some ways of benchmarking how much morphine should be provided. 5 milligrams obviously is too little. There's a defined daily dose system that was developed, but we think that the Europeans probably are closer to where it ought to be, rather than using North America as a benchmark. Certainly not. And that was around 12 milligrams per capita. In India, you are at 0.25 milligrams per capita for morphine use. So don't need to say more about that. I think that, and there, you see some very odd numbers here, and that's because you had a period when there was no reporting, or at least there was, you know, no reported consumption. There may have been consumption, but not reported. And then a sort of a makeup year in 2007, and then you've seen, you know, actually you're seeing a gradually increasing, you know, trend line over the past 10, 15 years, but it's still really, really low compared to the global average or the need. Over 80, according to International Narcotics Control Board, over 80% of the world's population lacks access to opioids. This is if you put all the opioids together, it's about 33 milligrams per capita. India is, when you put, actually it's pretty much fentanyl and morphine. It's only 0.5 milligram per capita. We measure levels of palliative care development. You may be familiar with this, the 6 levels. Level 1, nobody, can't find anybody even interested in developing palliative care in the country. 2 is people are developing it, but no one's yet providing services. 3, there's isolated provision. 4, generalized provision, but then 2 levels of integration, primary and advanced. Looking at the 198 countries we looked at in 2017, you see predominantly it's almost half of the world's population that's at level 3A, which is that there's at least one service and some delivery, but it's not very well developed. Only about 15% at the higher level of integration, and almost 2/3 of the country with either no or very limited access to palliative care. We did improve. We have seen improvement over time. We have, since 2006, there have been 3 different waves of measuring levels of palliative care development. And in 2006 to 2017, we have fewer countries without palliative care, more countries beginning to provide palliative care, and more countries integrating into the healthcare system. The Global Atlas also has a lot of examples. In the first one, we did Kerala in the first edition of the Atlas. The second edition has 12 countries that are highlighted, a program that we're involved with in Bangladesh. Mongolia has an exceptionally good specialist training program. Thailand, the first hospice in Africa, is still going, and they're doing pretty reasonably well. And in yeah, if you have a chance to review these and look at some of the innovations, I think it'd be useful for you to just take a look at that. We have seen, when we first measured the number of services and the number of people in 2011, we had 16,000 services caring for about 3 million. Now that was increased in 2017 to 25,000 services caring for 7 million patients approximately. So we are able to measure that sort of progress. And we've made a lot of policy progress in palliative care development, getting the definition, getting our World Health Assembly resolution in particular in 2014, but also included in cancer and dementia and primary care. And we aren't just, it's not just good health and well-being in terms of the sustainable development goals that we're aiming for. We think palliative care also helps reduce poverty. It helps provide better education and helps, we hope to address gender, we should be addressing gender inequalities and some of these other things like decent work and such. So finally, some challenges for you as you are the future leaders of palliative care. These are the things that you're going to have to help us overcome. We have to make sure we double down on education to provide more and more education. We have most of our healthcare dollars go to acute care, and 80% of the need is for actually chronic care. And so we need more services and more funding in the community. We need that capacity to deliver more home-based care. We need not just available, but accessible and affordable medicines for people. We need more compassionate communities that support palliative care. It's kind of an extra layer of support for those with serious illness and those who are grieving. And finally, actually, we believe palliative care, we thought 40 years ago that we would be out of business in 20 years because we just would, change the healthcare system. And of course, we failed at that. But what we have really in palliative care is a model for how healthcare systems should be operating. Actually, it's really a model designed especially for people with non-communicable disease. It's the kind of holistic and whole person, multidimensional care that all healthcare should be providing. On that, I will thank you very much for your kind attention, and we'll move on. Thank you.
Thank you, Stephen. I see there are a few questions, but I believe we can now go with the session from Dr. Devi, and we'll take the question at the end. Is that okay?
Okay. Let me share my slides and. Okay, is this visible? Okay. Am I audible?
Yes, yes.
Thank you, Dr. Sunil, and hello, everyone. Greetings from Bhutan. Firstly, I would like to thank Dr. Sunil and team, Dr. Raj, and the team at Pallium India for giving me this opportunity. Well, I came to Pallium India in 2016, Dr. Sunil, and ever since then, my training in Pallium India has changed my whole life, to be honest, especially my career. Well, I really feel I'm still a novice in palliative care, although I have completed a PhD in palliative care recently. I honestly have very limited clinical experience in palliative care, and having to deliver this lecture along with Stephen Connor, whose work I have read so many times in the last 5 years, is such a privilege and honor. And thank you so much. I'm wondering whether in the group there's anyone who is wondering where on earth Bhutan is, I thought I will just let you all know that Bhutan is here, a very tiny dot in the world map, located in the Eastern Himalayas. And we call ourselves that Bhutan is sandwiched between the two giant nations in the world, China in the north and India to the south. And it has a total area of about 38,000 square kilometers, and our population is less than 800,000. So we are not even 1 million population. Bhutan is predominantly a Mahayana Buddhist country, and gross national happiness is our developmental philosophy, a concept coined by the fourth king of Bhutan. At the moment, we have fifth king. Our fourth king is still alive. And it's a concept where the nation's development is measured by the happiness and well-being of its people and not by the economic gains. And I also thought I will mention here today that post-COVID, Bhutan has revised its tourist tariff. And today, every foreigner who comes to Bhutan, irrespective of whatever purposes, be it educational, official, or as tourist, needs to pay $200 US per person per night. So I've been telling my friends around the world to have patience for a while before they decide to come to Bhutan, because I have recently heard from a reliable source that it could change. It could be that the policy could be revised, but for now, it is $200 per person per night, which is very expensive. And I don't know whether you are able to see the whole slide, but I thought I will show, this is our national dress. And unlike other countries, men in Bhutan gets to wear a knee-length go, and women wears an ankle-length dress called kira and a jacket. And this picture is an icon for Bhutan. It is a sacred Buddhist temple, but a very popular tourist site in the country. It's the Tiger's Nest, located in Paro, where the international airport is. And so to start and proceed with our presentation, although having listened to Stefan had already provided so much of insights on the challenges of palliative care around the world, I thought I will start with a typical case scenario in a low and middle income country with regard to palliative care. So maybe I'll read the scenario. A 35-year-old Mary and her 7 children lived in a small village in Africa. A year after her husband had died of AIDS, her eldest son, 14-year-old Thomas, started experiencing pain in his right knee joint. Initially, neither Mary nor Thomas worried about the pain because their sole focus was to work every day and make and earn a living for the family. 2 months later, his pain started getting worse, and he also developed swelling in his right knee joint. He could not walk, and gradually he could not walk at all and groaned with pain every night. Their neighbors advised Mary to take Thomas to a hospital some 500 kilometers away from where they lived. With whatever little she had saved, Mary took Thomas to a hospital, leaving her 6 other children with their neighbor, who themselves had very little to feed their own family. In the hospital, Thomas underwent several medical investigations, including biopsy, which found out that he had osteosarcoma. Thomas had to remain in the hospital for treatment. He was given non-steroid anti-inflammatory drugs, but his pain was hardly controlled and it was getting worse. A week later, Mary had to return to her other children and left Thomas in the hospital, hoping that he will be cured when she came back. Being in a new environment, all alone with severe pain, Thomas cried under his blanket every night. He missed his mom, his siblings, and his home. 3 weeks later, Mary returned to the hospital where the doctors told her that Thomas needed a below-knee amputation of his right leg. Trusting that it will cure her son, Mary consented for the procedure. Following the surgery, Thomas actually started getting worse. He started coughing, could not eat anything, and had continuous unrelieved pain. Mary was increasingly becoming anxious. And 2 weeks after the surgery, Thomas died in the hospital in distress. Because she lived far away from the hospital, she had to bury her son near the hospital and returned home, heartbroken. I come from a low and middle income country, and this is very typical in a low and middle income country. So I thought we will look at what low or middle income country mean to us. There are different terms like LMIC, LIC, a low income country, developing countries, and third world countries. To me, when I consider these terms, the first thing that comes to me is poverty. And poverty where there's hunger, and then as Stefan had a list of lack for all those palliative care, there's lack of shelter, lack of money, lack of education, lack of healthcare, and then there's lack of human dignity. And all this leads to all a complex suffering. When there is lack of everything, there's also negligence from a human part. There's so much ignorance. There's corruption almost everywhere. And so when everyone is suffering, there's also very little kindness and compassion around. And the current key challenges that the world is facing is, we are all aware that the population in the world is aging, and it is in fact a serious concern in the low and middle income countries. It is estimated that by 2050, low and middle income countries will be home for about 80% of people above 60 years of age. And aging is associated with an increase in chronic illnesses. By 2060, it is estimated that about 48 million people will die every year experiencing serious health-related suffering. And of that, almost 83% of these deaths will happen in low and middle income countries. Now, when we say chronic illness, it is just a complexity of suffering. It's not just physical pain and discomfort, but there is psychological pain, there's emotional pain, so much of social pain, spiritual distress, and the needs of caregivers and families are immense. All these complex needs being termed as total pain by Dame Cicely Saunders, the founder of modern hospice and palliative care. And I think all the doctors here would agree with me that Hippocrates, the father of medicine, some 2,400 years, has emphasized that the focus of medicine should be to cure sometimes, to relieve often, but to comfort always. But as medicine developed, I think this crucial aspect of comfort started getting marginalized. And so Dame Cicely Saunders, who founded the modern hospice and palliative care movement, emphasized that palliative care is to address that total pain. It is to ensure comfort and improve quality of life of patients, even if the prospect of cure is limited. So palliative care focuses on symptom control in patients, along with disease management, and also emphasize on support all throughout the illness trajectory, extending to grief and bereavement support. And to achieve this, there has to be a proper care planning, counseling, communication playing a vital role, and underpinned by compassion and empathy. And I was arguing and I was discussing with Stefan a few days ago that palliative care has to be a a fundamental human right for every global citizen. And WHO and many other palliative care organizations do emphasize this and do focus on its as a vital human right, basic human right. Now, how does palliative care help? In the past, palliative care was integrated after the disease-modifying therapies have failed, and when the disease-modifying therapies have exhausted, then palliative care was integrated. But today, studies and evidence have found that integrating palliative care at the diagnosis of an illness makes all the difference, and then continuing throughout the illness trajectory at the end of life and extending to grief and bereavement support. There are several evidence and resources indicating that effective and timely palliative care not only improves the quality of life of patients and families, but also extends the life expectancy of patients and also reduces healthcare costs. Palliative care can provide, it's found that more than 90% of patients with advanced cancer gets relief from physical, psychological, and emotional and spiritual problems when confronted by a terminal illness. So that's how it makes a difference with palliative care. Now, the need for palliative care in LMICs, as I said, mentioned earlier, the world's population is aging, but it's more so happening in the low and middle income countries. And NCDs is accordingly accelerating. And so the demand for palliative care in the LMICs is only going to increase. As Stefan mentioned, almost 58 million people in the world are in need of palliative care, and around 78% of adults, and almost every children, as we saw in the map that Stefan showed us, that almost every children, more than 97% of children requiring palliative care are in the low and middle income countries. And also, a tragic reality in the low and middle income countries is diseases are often diagnosed at an advanced stage where palliative care is the only option. I've been reading this sentence for the last 5 years, and just recently I came back from Australia to Bhutan and found that my mother-in-law, who had been seeking medical help for the last 5 to 6 months, and the doctors at the National Referral Hospital in Bhutan did not find anything. So we thought we will take her abroad, took her to Vellore, and found out that she was actually at an advanced stage of pancreatic cancer. And I'm at the moment struggling to ensure that she receives as best as possible palliative care. So this is what happens in palliative care. It was an irony for me to return home after completing my study in palliative care and to start, taking care of my own family member. And as we saw that the need for palliative care, for example, how immense the need is in the world, more than 80% of the need for children, is in the low and middle income country. And as Stefan mentioned, there are multiple areas where palliative care is needed in the low and middle income countries, ranging from malnutrition to HIV/AIDS to spinal cord injuries related to unsafe working environments, violence of all kinds, injuries, multi-drug resistant is increasing, dengue, hemorrhagic fevers there. The immense burden of NCDs like cancer and organ failure, dementia, neurological failure, and old age and frailty. Besides this, in the low and middle income countries, palliative care also need to make sure that patients and families have enough food to eat, clothing to wear, shelter, and also make sure that there's safe drinking water. Also making palliative care extends to making sure that the children's education is taken care. And I know Pallium India is doing so much on making sure these patients' children do not drop their education when they are financially affected by the illness in the family, and also financial support for the patients and families. Now, I thought I will just mention about what happens when there's no palliative care, especially in the low and middle income countries. Well, in the low and middle income countries, there are people who are rich, and those rich people can afford to doctor shopping, change hospitals, go abroad, and then avail a sophisticated intensive care units. But when there's no palliative care, even the rich people miss quality and meaningful care. They die in a complex ICU with poor quality, with poor meaning of, they die alone away from their loved ones. On the other hand, the poor cannot afford curative treatment nor avail any symptomatic treatment. So without palliative care, both rich and the poor experiences poor quality of life and die a miserable death. If available, palliative care ensures quality and meaningful whatever remaining days, a dignified, respectful, and peaceful death. When I was doing my PhD, I was in Bhutan for my field work, and I involved, because I was doing a needs assessment for palliative care in Bhutan, and I involved patients, families, and healthcare professionals. And one of the doctors who was involved in the home palliative care service that was just started in the country at the National Referral Hospital, I still remember what he said. He said when he started going with home visits for, initially they started with cancer patients. So when they started, he told me that he felt, why didn't we start this program some 10 years ago? It doesn't cost much, but makes all the difference, he said. The patients were happy, they were satisfied, the family members were happy as well, but it was very satisfying for the care providers as well. This doctor had joined home palliative care service, and he told me that he was particularly interested in palliative care because he had lost his mother to cervical cancer when he was a young medical doctor. And so he thought, why was palliative care not there when his mom was struggling and he didn't know what to do for her? And as we saw the state of palliative care in LMICs, listening to Stefan, we realized that palliative care is well established. It is established specialty in affluent countries. And there's so much of gap between the developed and developing countries. So with this gap, in 2014, the World Health Assembly passed a resolution to strengthen palliative care, make it as a comprehensive care component throughout the life course. The World Health Assembly also emphasized that palliative care has to be an ethical responsibility for the healthcare system and for the healthcare professionals. And it's almost 10 years, and despite being cost-effective, a humane approach, and a realistic approach, palliative care still remains a huge unmet public health need in most LMICs. Now, as emphasized by Stefan, some of the barriers into palliative care in low and middle income countries are that limited or a lack of awareness about palliative care and its benefits among the doctors, healthcare professionals and nurses, because even some of the doctors do not know the concept of palliative care. Our policymakers do not know about it, and forget about the public, our patients and families. You know, I was quite moved by the patients. You know, I was interviewing patients, and they didn't even know that they had a right. They have a right to, you know, comfort care. The patients that I interviewed mentioned that they were so happy and grateful for the medicines and admissions they were given, when at the same time they were, you know, facing severe pain while in the hospital. So there's so much lack of awareness about palliative care. There's misunderstandings about palliative care. Often health workers also feel that palliative care is just an end-of-life care. In Bhutan, palliative care is still understood by many healthcare professionals as end-of-life care only, and that palliative care is only when therapeutic treatment fails or exhausts. And also, many understands that palliative care is just being kind and compassionate to the patients. When I came for fieldwork in 2019 from Australia, I also made a point to meet the Prime Minister of Bhutan, because he's a medical doctor with whom I had worked, and he had become a Prime Minister when I left for my studies. So I just went up to meet him, and he asked me, what am I working for my PhD on? So I said, I'm developing a suitable model of palliative care for the country, a contextually based palliative care model, because I said, like, it is quite a young concept in Bhutan. And the Prime Minister was saying, no, it is not a new concept. We do have lots of compassion for our patients, you know. So often, even health workers do feel that palliative care is just being compassionate, when at the same time, patients and families' practical aspects, including pain management, is not adequately addressed. And as you know, very clearly emphasized by Stefan, research on palliative care is limited. In fact, in many of the low and middle income countries, research itself is a very still at a very infant stage, and so was it in Bhutan. When we didn't have research, we didn't know the need for palliative care. Suddenly, when we assessed the needs for palliative care, we found out there's an urgent need for palliative care. So likewise, research is one important aspect. And then all this policy, organizational, and system barriers. Like, I realized that palliative care is not yet included into the spectrum of healthcare. When so much of emphasis is given on preventive, promotive, curative, diagnostic, and then rehabilitative. After that, there is no palliative care, you know. Palliative care is not yet included into the system, into the healthcare spectrum. There's lack of national plan for implementing palliative care. The national health policy, like in Bhutan, does not mention palliative care anywhere. The other barriers are shortage of doctors, nurses, and other healthcare professionals. It has always been a problem, and I think it will always be a problem. More so today, many of the professionals are leaving the country. As much as doctors and nurses are leaving, from Bhutan to go to developed countries, especially like Australia, I'm sure other low and middle income countries are facing the same trend as well. There are a lack of palliative care trained healthcare professionals. The home care team in Bhutan, who runs a small home care team at the National Referral Hospital, have attended 10 days of workshop at Pallium, India, and they are running a home palliative care team. So we don't have trained healthcare professionals. Many LMICs do not have trained healthcare professionals. There are limited infrastructure. And as mentioned by Stefan as well, that there are insufficient access and availability of essential medicines for pain and other symptoms. There are also psychological and social, cultural and financial barriers when it comes to palliative care. As I said, mainly understood palliative care, mainly misunderstood as just an end-of-life care, but also in many LMICs, I think we still deny death, and then we fear to discuss about death. A very practical experience from my own perspective that had I not gone through palliative care education, it would have been such a challenge to let my mother-in-law know that she is diagnosed with a terminal illness. None of my family members agreed initially that she should know that she's diagnosed. But with my education in palliative care, I could make my family members understand that she has a right, because she was increasingly curious about what was wrong with her. And so we could gently let her know that she is diagnosed with a cancer initially, and then that we will do everything possible for her to make sure that she is comfortable. And that made all the difference in the treatment approach today. So likewise, it's very difficult. Most of the patients in low and middle income countries are not informed of their terminal diagnosis. Patients hardly know. I had a monk patient who, monks usually, practice their whole life, and they feel that their end of life is the most important moment in their life. But the monk who was dying of terminal lung cancer did not know he was dying. He died unprepared. He did not know that he was dying, and he was in such a severe, uncontrolled pain, and so he died in such a distress. Even medical professionals like doctors and nurses still considers death as a failure, and so it becomes difficult for them to attend to a patient who is dying. Financial implication was one of the main challenges faced by patients in Bhutan, although healthcare is completely paid by the government. Patients and families still face financial implications when diagnosed with a life-threatening illnesses. So where in countries where they need to pay for healthcare costs, it is a catastrophic implication, not just to this family, but to many generations down the line. So the emphasis to deliver palliative care in low and middle income countries, the World Health Organization and other palliative care organizations has emphasized integrating palliative care into the public health system since the early 1980s. And now the universal health coverage emphasizes that there should be equity and access to essential health services, including health promotion, disease prevention, treatment, rehabilitation, and palliative care without financial hardship. There are enough emphasis being made. In 2018, the Astana Declaration emphasized that palliative care needs to be strengthened from a primary healthcare approach. And also there are evidence that palliative care needs to be socially, culturally, and spiritually appropriate in the individual country. I had colleagues around the world who said that they went to UK to learn about palliative care and then returned back home and started integrating what they have learned in UK, the same model in their countries, and then they said it was a big failure. I've learned that we cannot borrow the palliative care model from other countries, but need to make it contextually appropriate. And I think that's what Dame Cicely Saunders said from the very beginning, that go around and see what has been done in other countries, but make sure that you develop your own model for suitable for your country. So in the past, in the 80s, the WHO emphasized that palliative care has to be a public health model, and in the beginning, it was those 4 strategies, like policies and making sure that there are right policies to integrate palliative care into the health system, and then making sure the essential medicines for palliative care, especially opioids, are available, accessible at all levels of healthcare, making sure that there is education on palliative care among the healthcare professionals, policymakers, patients and families, and the public, and then implementing palliative care at all levels of healthcare. And today, as comprehensively explained by Stefan, that the new conceptual model for palliative care includes research, which is a very, very important aspect of it, and then involving the communities and empowering people in the communities, and making sure that the community is aware and then involved in the palliative care service. So what do we need to do? As I said, I'm a beginner. These are what I'm emphasizing for Bhutan at the moment, and as the participants here, as a young future palliative care enthusiasts, I think it's very important to emphasize that we integrate palliative care into the public health system, especially in a low and middle income country. I've read during my PhD that it is neither feasible nor necessary to develop separate palliative care, but to integrate it into the public health system, and making sure that it is palliative care is emphasized as much as other aspects of healthcare components are aspect, like preventing, promoting, diagnostic, curative, rehabilitative, and palliative care. These are all vital in the healthcare system. Start with education, and that's what I'm doing at the moment. Emphasize palliative care education for pre-service healthcare students. Conduct workshops and trainings for in-service palliative care professionals. Educate the policymakers. Once the policymakers are aware about palliative care, and making them understand not just the benefits to patients and families, but making them understand that in the long run, palliative care will also reduce the healthcare cost. Lobbying with them, because political involving politicians and making sure the policymakers are aware of these will make all the difference. Making sure that our patients and families and the public are aware about palliative care. And then developing suitable palliative care strategies, guidelines, and policies. Making sure that essential palliative care medicines are available at all levels of healthcare, because at the moment, like for example in Bhutan, essential medicines like morphine is available only till the community hospitals. The primary health center do not have opioids. All they have is paracetamol and ibuprofen. Now the patients, after getting diagnosed at the National Referral Hospital, and once their therapeutic treatment is completed, they return back to their communities. And that's when they face, they struggle, they suffer, because they run out of their pain medications. And then the community health center, the primary health center, there do not have essential medicines like opioids. And that's when the quality of life of patients is hampered. And so with training and education, the primary healthcare providers can very comfortably provide opioids. Like that's what was done in Uganda, that nurses and healthcare, the clinicians in a rural part of the country were trained in prescribing morphine for patients. And so without doctors, they could provide morphine to patients in rural communities. Involving communities, as emphasized by Stefan, involving communities, local leaders, the volunteers, and other relevant stakeholders. Palliative care is a multidisciplinary team approach, and so it's vital that these different stakeholders are involved. Conducting quality research, collecting quality data, conducting research will help in identifying the needs and also supporting, giving us evidence that palliative care will make a difference. Developing contextual-based palliative care, as I emphasized earlier, making sure that palliative care is individual, patient, and family-focused, and also socially, culturally, and spiritually appropriate. And then they are available at all levels of healthcare. So with that, I would like to conclude with this, that governments in low and middle income countries may have an excuse that they do not have adequate resources and say that we have limited resources. And so they may use it as a justification for not having adequate palliative care service. But as a palliative care advocate, we have to make sure that it is an obligation that every effort must be made to develop contextually appropriate palliative care within the existing resources. We have to help make sure this and the government understands that it is not just money that involves in palliative, developing palliative care. And it is affordable, it is doable. And with that, thank you very much. These are some of the references that I've used to prepare this presentation. Thank you very much, everyone. Happy to answer questions if anyone has.
Thank you, Dr. Tada. And now the session is open for discussion. Anybody can ask any questions. Anybody?
Don't be shy.
Sir, this is Dr. Punita here.
Getting echo.
Can you hear me?
Yeah, yeah.
Okay. Sir, my question is, India has both public health model and private setups. So if we want to involve community, how to do in private care setup?
Well, interestingly, the majority of licensed hospice programs in the United States are actually for profit, not private. I mean, not for profit. And palliative care shouldn't really be different in a proprietary and a private, or I mean a public setting. But there may be some. I mean, it's really a question of getting the people who own the business to understand that it's possible to do it with in a business setting. The difficulty is that we have to have healthcare systems that reach everybody. And if you have a system that's proprietary or for profit, they're not going to care for people who don't have money. I mean, or maybe they'll care for a very small number of them. And that's the big difficulty. That's why, really you shouldn't be denied access to palliative care because you have limited resources.
Thank you.
Yep. Tara mentioned about the human right issue, which is a kind of a thorny one, because we all believe that palliative care should be, everyone should have a right to access palliative care. We've gotten palliative care included in all those important international documents, the World Health Assembly, the governing body of World Health Organization, various statements, but there are there's no right to palliative care referenced in a obligatory document like a treaty or convention where, you know, governments sign it and then they're obligated to actually do it. So we're trying to get it into the pandemic preparedness and response treaty right now, and there's been a lot of resistance. Governments don't want to be obligated to do things. They don't want to pay for them. They would be made to pay for them.
You said the United States has more of home-based palliative care than any other country. So can we then India adopt the private sector of India? They can adopt that same model.
Yeah. The thing in the United States is though that the government pays for it.
Means you say insurance money.
Only about 1% of the people don't have any insurance that come to palliative care, because by the time they get to us, they're broke anyway because they've, you know, spent all their money.
Insurance covers the palliative care also.
Well, it covers hospice, which is, of course, hospice is all palliative care we think of as a bigger circle. Hospice is within that circle. It's all palliative care, but it's not everything. So palliative care is kind of a bigger frame, you know, for caring for people. Hospice is more end of life care. Medicare and Medicaid, which are the two main insurers in the United States, cover hospice care. They cover many parts of palliative care, but they don't cover it as a package per diem thing.
Thank you, sir.
So Stephen, there is a question about one of your slides. I think that was one on global consumption of morphine. And Dr. Parul asked what is meant by not applicable in that slide. Global consumption slide.
It's not, it's really meant to be not available. Let me pull up this one. Okay, I see, because there is not available and not applicable. That's a very good question. I'm not sure why it would be not applicable. This is a statistician who did that. Let's look at that closely. Oh, that's just Greenland, which is part of Denmark. I think that was the reason for it, because it's included under Denmark's data. Yep. Does that answer your question?
Anybody else?
Sir, I have a question for both of you. Basically, we are a group of students who are practitioners who are now newly into palliative care. What will be the essential research what India needs right now, so that we can take up, we'll have good direction of what we should not do some meaningless research. We want some basic ideas with which both Dr. Tara and you can tell us. Where should we start with? What is very important? I'm asking both of you. Sir.
Thank you for the question. From my experience, as I said, I don't have much experience worldwide, but I know in India, India is such a big country, right? And if you are focusing to develop palliative care in a particular state, I would think of assessing the needs first. Assessing the needs for palliative care, because that's what opened my eyes into the importance of palliative care for Bhutan. You know, we assessed the needs for palliative care where we involved not just patients, but patients, their family members, and the healthcare professionals. And I also did not just quantitative research, but qualitative research. And I think Stephen also mentioned the importance of qualitative research, because listening to the lived experiences of patients and families, and also the healthcare professionals, gives us all the insights about how crucial palliative care is. So from my own personal experience, I would say assessing needs for palliative care involving patients, families, and healthcare professionals, and then developing an appropriate framework or a strategy for palliative care, because that's what I did for Bhutan, and that's what I feel in a way would be important if you are looking at developing palliative care for the first time. Well, if there's already a palliative care service, then maybe looking at individual diseases, for example, palliative care for renal failure patients, palliative care needs for cardiac patients, palliative care for cancers, advanced cancers. So I don't know whether I answered your question, but that's what I would say from my experience. Thank you.
I totally agree with Dr. Tara. That actually is, I mean, the perfect answer to that question. Yes, Sushma, Dr. Sushma and I have been trying to get Medical Research Council of India to approve a protocol for that, because and we need people in every different state in India to help carry out that research question. Dr. Raj, did you want to say something?
So, one question to you. I'm working in a tertiary level private hospital. We have the palliative care facilities with home care, everything. But one thing which I have practically faced is trying to convince the consultants in other departments other than oncology to part away with their or participate us also in that care of their terminally ill patients, like cardiac patients who are in end-stage cardiac failure or nephrology with renal failure. It's very difficult to convince them. So you said that we have to involve policies and we have to get all the healthcare professionals into this thing. But how do you get this message across these very senior consultants who are very reluctant to do so?
You just, well, for starters, Dr. Gopi, you are not alone. That is a problem in every country. And it is, we had trouble in the beginning getting the oncologists on board. They said, oh, we don't need, we do all that stuff anyway. And they don't. And, to some extent, I hate to say this, but sometimes you just have to wait for generational change to happen.
Sure.
But
we may not be around then. We may not be around then.
Tell them how much they appreciated getting the referral to palliative care.
Sure.
It's
Thank you.
Yeah.
Maybe if I could just add, I just remembered that when I went to Pallium India in 2016, I believe before our group, there was a group of, there was another group, and among them, I think there was an oncologist who attended the training. So at the end of 6 weeks, when the participants had to give feedback, because normally Dr. Raj and the team makes sure that the participants gives feedback at the end of 6 weeks. And I believe this, the oncologist, because we were told what the previous participants, mentioned. And so I always remember this. One of the oncologists who attended the 6 weeks palliative care training said, after attending this training, I now feel that my patients are human beings. Okay. So maybe give them a lecture on palliative care and the differences that it makes. I think it would help, but as you mentioned, very senior consultant, and in a place like ours, there's so much of hierarchy. That's what I'm struggling at the moment. So I'm starting from down below, helping the nurses, helping the residents, sitting with them, discussing case studies, and then maybe one of the residents may one day tell the consultant that this is what palliative care does, and then it makes all the difference. So might help, but as Stefan mentioned, it might take a generational, long duration. Thank you.
Dr. Paru?
Yeah, I have a question for ma'am. Ma'am, when you said that you did your research in assessing the needs for the palliative care, did you target the doctors or patients or the caregivers? What was the target group?
Thank you, Dr. Parul. And yes, as I said, I involved patients diagnosed with advanced illnesses and their family primary caregivers, and also healthcare professionals, including doctors, nurses, physiotherapists, pharmacists, and traditional physicians, because in Bhutan, traditional medicine and allopathic medicine are both under the same Ministry of Health Ministry of Health, it functions under the same ministry. So we have traditional physicians in the same hospital providing traditional medicine. And patients often feel that when their allopathic treatment doesn't help much, then they go to, there's at times cross-referral as well. So I did involve, and while I did quantitative surveys, I also did in-depth interviews with patients and families, but focus group discussions among healthcare professionals. So then I looked at their different perspectives, patients and families' perspective for the need for palliative care in Bhutan, and also looked at the healthcare professionals' perspective on the need for palliative care. So yes, I did involve all those three categories of people.
Okay, thank you so much, ma'am. Thank you.
Sunil, with your permission, Stephen, thank you for asking me. And Stephen and Tara, we couldn't have had a better opening for these masterclass sessions. Great choice, Sunil. Thank you very much. I had one comment to make about Punita's question regarding research. Thank you for the question. And Sunil, with your permission, Sripriya, may I share one image?
Sure, sir. Just a moment, giving you the access. You can do now.
Thank you. I just thought Punita's question was very, very relevant. Sorry. Sorry that I'm messing that up. Just 1 second. We hope you can see that image. This publication, bit old, I must admit. I hope things have changed, but maybe not much. 15% of the population lives in Euro-American countries, and 93.5% of published research is from this 15% population. Low and middle income, the non-Euro-American countries have 85% of the population, but only 6.5% of the publications. What we are reading and what is getting into the textbooks are really focused on what they found in this part of the world. So, continuing with Stephen's and Tara's responses to that, very good. Yes, we need to know what the needs are. What are our people suffering from? Is it really what's written in the Oxford textbook of palliative medicine? What about caregiver burnout? That beautiful phrase, caregiver burnout. What happens to people here? Why are people being deserted? What happens to the poor? How do they die? The needs. And secondly, equally importantly, the solutions. I learned palliative care really from the West, and we all learned from the Western experience, and that has been precious. Let us not undervalue that. Having said that, if we just stop there, then we wouldn't know whether what we are doing is the right thing. Where are we providing palliative care from? Mostly, or except in Kerala, mostly from tertiary care institutions. Do the really deserving people ever get to us? Or even in Kerala? what happens to the vulnerable population? Do they ever get palliative care? Any number of categories of vulnerable population. So Punita, I honestly believe that your research should be rooted firmly on our grounds. What are our people's elements of suffering? And are the solutions that we are offering the most effective and cost efficient? My 2 cents worth. Tara, Stephen, your comments would be very valuable with your global experience.
Well, I think we're both saying the same thing, which is that, and I love that quote from Sicily. I use that a lot, to go around and see how, different palliative care is being, delivered in different places and come up with your own version. I asked Sicily one time, should we drop the hospice and just use the term palliative care? And she says, I don't care what you call it, just do it. And the needs are very different. I mean, our project in Bangladesh is nothing like the kind of palliative care we provide in the United States, and it shouldn't be. I agree with you wholly. And we need more research. And actually, things have improved a little bit. I thought I saw a more recent publication. It's still abysmally, lopsided, but we're starting to see more literature starting to be published from low and middle income countries, which is where almost 80% of the need is. It's an 80-20 problem we have in the world, which is that 80% of the care is being delivered in high income countries, and 80% of the need is in low and middle income countries. And we really need to turn that around. Dr. Tara?
Yeah, I think I also agree. I also have the same answer, but yes, when we do a local needs assessment, we come to understand our issues, but also we come to understand what are our facilitators. We know what is available in our settings. And so it gives us a kind of confidence. Well, I don't really have a global experience. Well, I've read so many literature around the globe, but then as what Cicely Saunders says, go around and see what others have done, but then build up your own version. So when you have read about others, it gives us an idea about where to focus and what are our barriers and what are our facilitators. I think I really would like to emphasize there are so many facilitators in our context. Like we have such a close family, support. At the moment, I'm struggling with my mother-in-law. I have to go and see her after this presentation because we have started her on morphine today, But then I don't have to worry that she's all alone. She has I have my sister-in-law with her. There are other family members. There's neighbors there. There are others. We also have very rich cultural beliefs and values that also helps. Like in Bhutan, we have the fundamental principle of Buddhism is impermanence of life. So patients and families knows that impermanence is a reality. At certain point of time, they forget that they need to be cured or they don't want to die. They just want symptom relief. Their biggest fear is pain and distress. So we will understand our own barriers, but also what is available already there. So that's what I feel. And Dr. Raj, I get goosebumps listening to you. Your lecture on palliative care ever since I attended in 2016 has changed my life. And it's really, so precious listening to you, and such a learning for me today from Stefan and everyone. Thank you.
Dr. Kavin Kumar asked about the per capita consumption. Is that more appropriate compared to those with the need of palliative care?
Well, I mean, from a research standpoint, it's a better benchmark because you can compare from country to country, and the needs vary from country to country. there's another measure we're using, which is more opioid consumption per cancer death. That's a way of also looking at it. So I think you can look at it both ways. Though cancer obviously isn't the only condition that we're concerned with, but it is the one where people, the highest percentage of people needing opioids from other diagnostic groups. But there's an actual. The problem with all these measures is that we don't have good data in a lot of countries on cancer mortality, and the data on opioid consumption isn't very accurate either. So there's been criticism of both of these measures, but they're very rough measures, shall we say.
Yes.
So
Okay.
I think there is one more question. Is there a simple and standard tool to screen for serious health-related suffering, which can be translated to my language to start collecting data? That's why Dr. Punita Vade.
Well, we use many. There is the Edmonton Symptom Assessment Scale revised that is pretty commonly used to screen for both physical and psychological distress. There's the distress thermometer for psychological distress. There's the International Palliative Outcome, the Integrated Palliative Outcome Scale from King's. It's a good quality of life measure, a good way of getting an assessment of serious health-related suffering. And they all use generally 0 to 10 scales. For severity. Any other thought, Tara, Dr. Tara? You have it?
Thank you.
Rajav,
Can-
would you
Can I come in there?
like to comment on SHS?
May
Yeah.
I? Again, Sripriya, one more slide to be shared. Stephen, I don't know if you have come across this, and Tara, I don't know. This was prepared recently by the National Cancer Grid. For anyone who does not know National Cancer Grid, it's a collective of the cancer hospitals in the country. More than 350 cancer treating institutions are members of this. It's an informal group, but doing remarkable work. I would encourage you to look at their Choosing Wisely India guidelines, also very valuable. So the National Cancer Grid arrived at this with a working group of several palliative care physicians. So I must say that, Stephen, you may find it a bit laughable. And let me take an anticipatory bail and saying this is only for preliminary screening. This will not give the answer to who all are in SHS, but a preliminary screening with only 5 or 6 questions where you score. So one is physical suffering, emotional, social relationship issues, more like spiritual, and one additional thing, mostly about financial losses. If the score is, it is suggested that if the score is more than a certain level, you go to second level questions. This has been written up for publication, has been tried out in some institutions, but by no means a finished product yet. Stephen, that is
promising. Thank you, Roy. That looks
Stephen,
promising.
that is possibly applicable to this country because of the huge load of financial suffering that happens in this country, the financial toxicity of treatments.
It's promising as a screening tool, yes. And there's a difference between screening tools and those that are used to measure how well we're doing, let's say, with relieving serious health-related suffering, which are more of the other tools we mentioned. It's like the stress thermometer in a sense. I mean, if you have stress about a certain
Yes,
employee.
yes. Thank you for that clarification, Stephen. Yes, thank you. What I mentioned was only a screening tool. Stephen is emphasizing that, and that's important to remember. It doesn't assess SHS as it is, but after the preliminary assessment, you go on to the detailed assessment. Thanks, Steve.
I think we need to wind up the session for now. It's already late.
Very late,
but,
very late.
I would like to thank Stephen and Tara, who has actually gave us a wonderful picture about palliative care across the world. And there are many things which I am sure when you go through the slides of Dr. Stephen and Tara, you will know it better. There are many things which we need to digest. Thank you once again, Dr. Stephen and Dr. Tara, for your wonderful presentation. And thank you everybody for attending this. And thank you, sir, for your comments. Thank you all.
Good night
Thank you.
and good day.
Thank
Do
you,
well.
Stephen.
Good day,
Do good
Stephen.
work and keep in touch.
Thank you.
Thank you, sir.
Bye.
Thank you very much, sir, and thank you for the opportunity. Happy to see Dr. Sunil, Dr. Raj, and good luck to all the enthusiasts, palliative care enthusiasts. Let me know if there's anything I can do to help you, because I'm also learning, but happy to learn together. Bye-bye.
Shake the world.
Sure. Thank you, both of you, for joining us in kickstarting this fellowship program, which we believe will crave out masters in providing palliative care, palliative medicine across the world. Thank you so much. So with the positive hope that we will continue the sessions with this enthusiasm, this is Sri Priya, along with Dr. Stephen and Dr. Tara signing off from TIPS. See you in the next session. Till then, everyone take care. Bye-bye.
Thank you.